Hi, everyone, and welcome back to the Fast Away podcast. I am thrilled to be here today with my OBGYN, with my gynecologist, Dr. Reyes. Dr. Reyes, thank you so much for being on the podcast.
You're welcome. Happy to be here.
You are the very first gynecologist we've had on, and I know that we already have ladies like putting their legs closer together and like, okay, I'm going to cross my legs. We got a gynecologist on here. But you've really helped me quite a bit over the past couple of years. And we're going to dive into some of the pain points that you've solved. But you also happen to be an expert on the topic of perimenopause and menopause. And you were telling me in the pre-interview chat that you are part of a menopause society. Can you share a little bit more about that?
So there is what was formerly called the North American Menopause Society, is now called the Menopause Society. They're just like the premier organization that oversees like practicing physicians, any healthcare providers that want to learn more and practice evidence-based menopause care. And they're basically North America only, but they put out like all of the evidence, guidelines, different things that we use to practice medicine. But they're really great and put out an amazing amount of just studies, and concisely they take them and they summarize them for practicing healthcare providers. So,
and you are coming out with a course for perimenopause specifically as well.
Yes, I am. I'm very excited about it. It's called Mastering Midlife and Menopause, and it'll be geared towards the patient. So not for healthcare providers, but for people who just want to learn about their bodies. So it's like basics 101, like what's going on? Why do I feel like this? And then what can I do about it? What are my hormonal options, my non-hormonal? It even touches on nutrition and exercise. So it's really going to be great. It's just got to get on the website live.
Love it. Yes.
But yeah, it's really informative.
When I interview doctors, I love to ask when and why you entered into the wellness space or that medical category. What really prompted you?
In general?
Yes.
Oh, gosh. I think I just loved science.
Okay.
I loved learning about like anything biology. And then the human body was amazing to me, like back in like college. And then I worked in a hospital, and I kind of got into that whole like just watching what it was like there. And I was actually just like a unit clerk that worked on a hospital floor. And so all the doctors, this was back in the paper days where they would just toss their orders in the basket and, and I had to enter them in the computer. And so I just got to kind of see like the whole just like system within a hospital. And I just kind of was hooked on, figuring out what my place could be in that. So yeah, that's how I first got into it.
When did you decide to go to school to become an OBGYN, and why did you choose that path specifically?
OBGYN I chose once I was already in medical school because it was a nice blending of surgery and medicine. So you had some relationships with patients, but you also had, some just really gratifying moments like doing a procedure and now the patient's better, or, so there was just kind of like a mix of everything of both like acute and chronic care.
Yeah.
So, and I did enjoy doing procedures. That was enjoyable back in school and still to this day.
Oh my gosh. It is a special type of person who says, I enjoy doing procedures. I don't know how you guys do it. Doctors, dentists, my hat is off to all of you. I can barely like give myself the teeny tiniest like baby shot without passing out. So
oh gosh. Yes,
I
you
watched
can't be that guy.
my son had to go to a dermatologist and have just this little mole removed, and I almost passed out. And the doctor's like, is mom doing okay? How's mom doing? And he was like 4 or 5, and I'm like on the floor. It was so embarrassing, but my hat is off to you.
Yes.
So I know that you are also a mom. How was it going to the hospital and delivering a baby when you knew that you could do it yourself? Like who was your OBGYN?
Who delivered?
Yeah.
So my very first, I have 3. My oldest, he was delivered by actually my residency classmate.
Oh, funny. Okay.
So she's
that's great.
Amazing. And then my second and third actually were delivered by an amazing midwife that was in the practice I was in prior. So, and my third was actually born in the water.
Oh, I love that.
It was like semi-unintentional. I was going to use it just for pain relief, but she came.
Okay, well, I will quickly.
Anyway, it was amazing.
No, that's fantastic. So I had my 4th in a beautiful tub up in my bathroom. I had candles, flowers, the whole. And then my 5th, I ended up bringing my birth team over during the day because my contractions started at noon. He was the first one that my contractions started during the day. So I brought them over. We all ate acai bowls. We went on a walk. And then I told my midwife, I said, I'm going to sit in the hot tub for 10 contractions. So I get in my hot tub in my backyard.
And it helps so much.
So much. Oh my gosh. Get in the hot tub. My husband's in there with me. 4 contractions later, he pops out.
Yeah.
In my hot tub.
I was going to say on the 5th.
It was a saltwater hot tub.
Oh my God.
But I had texted my 2 best friends when we got in the hot tub, just like a photo of me and Brandon in the hot tub. And I'm like, everything's going great, blah, blah. And then I text him like 30 minutes later with a picture of him, my 5th Ty in the hot tub with me. And my best friend's like, oh my gosh, was that intentional? I'm like, no, I had the whole beautiful setup in my master bathroom with the candles
This
and
is
the
not
flowers.
the plan. Yeah, that's how the 3rd was for me. I was like, that wasn't really what I was going to do, but okay.
Yeah.
Came out.
I love that you did a water birth, though.
Yeah.
Either way, I think that's fantastic.
I actually did it within the hospital. I don't know if they have it anymore.
Morton Plant?
Yeah.
Yeah, they do.
Yeah, they do? Okay.
Yeah.
I wasn't sure. I haven't been there in a few
Yeah.
years, but yeah, it's a really cool it's unique for a hospital.
Yeah. So when I delivered Lily, who just turned 6, I was like one of the first patients in the new Morton Plant labor and delivery area.
That's where I delivered.
They had in fact, when I toured the hospital, I toured the old part. And then when I ended up going into labor, I was in the brand new part. And I was like one of the new people. I'm like, oh, this is great. Okay. So we're going to talk about a big pain point that you solved for me, which I've referenced on the podcast and gotten a lot of questions about on DM. And then we're going to talk about perimenopause and menopause in general, because a lot of our ladies listening have questions. We have questions. We all have questions. So my entire life have had extremely heavy periods. It's just a thing. It's been a thing. I eat great. All about my lifestyle. I've personally resolved polycystic ovary syndrome with the faster way to fat loss. I've resolved my insulin resistance with intermittent fasting and whole food nutrition and blah, blah, blah. I am gluten-free, dairy-free. I don't have a lot of sugar, but it's just been a thing for me. So I went to you and I'm like, I'm over this. I have 5 babies. I am not planning to have another baby. What are my options? And you gave me my options. You said, A, you could get a hysterectomy. And a lot of the ladies listening, they've gone that route. B, you could do birth control, which I've tried. I've done probably 6 different types. I've done the mini pill.
Doesn't agree with everyone.
Yeah, I've done the Mirena. The Mirena, I was blue. It's the only way I can explain it is I had the blues. And then, I will just be honest with you guys. So both JJ and Ty, I was like trying natural family planning. Mama is not good at math. Okay. I am not good at I'm like, I got pregnant twice. Okay. So I'm like, I wasn't on birth control. I was trying the natural. It did not work. Yes. Also, Brandon was like 10 feet away from me, sneezed, and I got pregnant. So I'm like, I go to you and I'm like, I'm done having kids, but like, what are my options? We got, he got the vasectomy and you said, have you considered an ablation? I'd never heard of it before. And you said to me, there's a 95% satisfaction rate with this, where you have to explain the science of what it is and how it works, but it's been life-changing. So my periods now are so much lighter. I am so much happier. I can do normal life things that normal people can do. Any day of the week, any week of the month, any month of the year. That was not my reality in the past. So explain the science behind this a little bit.
So essentially you have to evaluate the uterine cavity as long as there's nothing else wrong. There's not like a polyp growth or a fibroid tumor or any kind of abnormally shapen uterine cavity. You can essentially go in, we place there's various ways to do it. Radio frequency energy in this case was like inserted into the uterine cavity, and then that energy basically destroys the endometrium. So that uterine lining that you build up and shed every month is no longer responding to the hormone signals anymore. So your hormones are still there. It's really, a lot of people say, oh, well, I go through menopause early. No, it's not affecting the ovarian blood flow or hormones at all. It's just affecting the part of the uterus that thickens and then sheds. And so therefore you either get no period or a lot lighter of a cycle.
Yeah.
So it is destroying a normal part of your uterine lining that, isn't going to bleed anymore, which is quite welcomed by most people that have had, really significant period issues. And it's not for everyone, certainly, but it's really, really good for people who have that like regular cyclic heavy bleeding and they just really need to do something non-hormonal. Like they don't want to take birth control, can't, they don't tolerate it. Kind of like you just described.
Yeah.
Many people have your experience. So it's not uncommon to need something non-hormonal.
And I have to say, it was like relatively painless for me. The day of, I had, just like a little cramps bit of downtime, little cramps, but no bleeding even that day, which I was like very surprised. And I remember the next month, I flew up to Connecticut for a charity race called Hell on the Hill, which is a 4-hour charity race where you're going up like a 45-degree incline, hardest physical event I've ever done. And it was day 2 of my period. And normally there's no way I would have been able to participate in something like that. Just no way. Just absolutely no way. And I was able to do all 4 hours. And I'm like, this is just, I can't even believe it that I'm able to do this. It was life-changing. And so for me, like 10 out of 10, highly recommend. But I'd never heard of it. And I think that there's so much stigma around talking about these issues, or there's a lot of just confusion and overwhelm with even also now perimenopause and menopause, which we're going to talk about.
Yeah.
But I just wanted to kind of draw attention to it and then explain to our audience what that even is.
Right.
So let's talk about perimenopause and menopause. Define for me, what is perimenopause? I know
what's going on.
Our Alex, so Alex D. Oliveira, she says it starts at, 35, for a lot. So define it for us.
So I think it's good to start with what menopause is first. So menopause is like this one day in your life where you've gone 12 full months with no period.
Wow.
And then that's it. And then today I'm menopausal. Everything after that's post-menopausal. So everything before that, so average age of menopause is 45 to 55, let's say on average 51 to 52. So this is like a time where like all the eggs, they're retired, they've run out. And so essentially you're born with all of them you'll ever have. And so then you never like regenerate them like sperm does every 90 days.
Crazy.
Yeah. So then perimenopause is the years prior to menopause. So your periods are still coming in early perimenopause. They're regular even many times. And then they may start to become irregular. And then you develop a variety of symptoms. And yes, it can be 7 to 10 years before menopause. You can start developing. So like symptoms of perimenopause. And I think that's the group, the early perimenopausal is where they really get, I don't want to say my colleagues are ignoring, but a little bit it's getting missed because they are reporting symptoms and they are told many times, hey, you're too young, you're having periods, these symptoms are just kind of normal aging and things like that. And it's not really identified, I think. Now, if you stop your period, it's a little bit more recognizable, I think, by an average, just any physician seeing you, hopefully. We hope. But there are, I think, just a lot of confusion in the perimenopause years. And I don't think there's not a lot of emphasis on education in the medical system on it. And so there's like a big gap in knowledge, even amongst OBGYN residents coming out. So a huge, huge gap. I think they say like 1 in 5 have received really any training on menopause. And so it's really a system failure rather than, individual doctors or anything. I mean, they're doing so many things. And even OBGYN is super broad. So to expect them to know is hard. It needs more emphasis. And I think it's changing. I think there needs to be a dedicated menopause rotation, if you will, for clinicals for them, for OBGYNs.
Yes.
Because people expect their OBGYN to know, and you're going to get variable responses. And that's what I've learned doing this is, I get a lot of referrals and from people who have an OBGYN, they're perfectly happy with this person, but they don't prescribe hormone therapy. They don't know anything about perimenopause, and they're like directly telling them like, yeah, I don't really do that, or they do try to do it, but they're rushed, and so it's just the system is difficult.
Yeah.
So
That
love
is
it.
a really interesting problem solve or solution to have them go through
Mhm.
a perimenopause or menopause section
Yes.
or however that
Yes.
verbiage is for
There's a little
doctors.
bit, but it's just so it's not enough for something that half the population goes through.
50%.
Yeah.
50%.
Yeah.
Yes, yes. Okay, so
Yeah.
let's talk about some symptoms because
Mhm.
I do think there is more awareness and there has been
Yes,
a
there
bit of
has
an
been.
awakening around this because now perimenopause is trending. We in the
Mhm.
Faster Way work with many, many, many
Yep.
clients in perimenopause. Our average age is 43.
Mhm.
I've been running this company for
Mhm.
several years, and every single year, our average age is 43. Every
Yeah.
year. I get it, it's
Yep.
like, and we'll have a bigger volume of new clients and a
Mhm.
bigger volume of VIPs. We have, let's say, triple, quadruple the amount we had a few years ago. Still, the average age remains the same, 43.
Uh-huh.
So, what are some of the symptoms that we need to look out for? And then we'll talk about problem solving.
So, I would say early, the ones that people report the earliest, like maybe you're 35 to 40, and not everyone has symptoms. I think that's
Yeah.
also good to say. But if you are going to have symptoms, many times it's like, I never had this difficulty sleeping before my period. I'm having PMS. I never had this before. I'm even like waking up and having a few night sweats, like in those 2 or 3 days before my cycle. Or some people have it around ovulation. There's some notable hormone drops and rises in a menstrual cycle that really affect people. And then usually, hey, I start my period and I really start to feel better again. And that's due to just the normal estrogen rise that's starting to occur in the cycle. But I'd say it's usually cyclic kind of symptoms at first. Then it may progress more to like continuous, like every day I start to struggle, or half the month I'm struggling now. There's only like a week where I feel good. So various things. Those are just some. But I mean, people report brain fog, fatigue, low energy. Certainly in your client's average age group, it's midsection weight gain.
Yes.
It's the insulin resistance. And these things are real and they are hormonal sources and in many cases. And so I think that's where people just really miss the boat in the regular medical field, is like they're like, oh, that's just like diet and like just only do that. And while it's super important, there's something happening within your body that is making it a little bit harder for you. But it can't be not overcome either. There's solutions.
Yeah.
So,
yeah. Okay. You described the life of so many of our listeners. So hot flashes a couple days before their period, hard time sleeping a couple days before their period, anxiety, maybe an increase in moodiness or depression, maybe additional fatigue, brain fog. And like you said, it will then build over time where it's now
waxes and wanes.
Yeah. Yeah. And, they'll go to the doctor. I heard a statistic this morning that with the rise of antidepressants, there's been a rise in suicides. So that is not the solution for so many people, but more and more women in their 40s and 50s, it's like the most biggest, growing group, are given an antidepressant by their doctor because they come in and they say, my mood is unstable and blah, blah, blah. Okay, well, here's a antidepressant, but it's not actually decreasing the amount of suicides because so many doctors in the medical field, they look in a silo. So there's a siloed approach instead of a more holistic approach. But what do we do? So what do we go to you? We ask for blood work. We sign up for your course. What are my options? How do I start problem solving this? And then
for these symptoms for perimenopause. So I think the best approach is to find like someone knowledgeable in the field, which is harder than it sounds. And so I say this all the time on my social media, and people are like, but it's so hard to find someone.
Yeah.
And, there is a lot of telemedicine now in various states. So you can find a Menopause Society certified practitioner that way. And if you go to menopause.org, you can actually find a physician or a practitioner. You have to be a little bit careful. The list isn't perfect. There can be people on there, like pharmacists can even get certified. So you do need to see like a healthcare provider that's going to be able to like prescribe. But that's probably your like best way. If you can find someone with the certification I have, that is probably your best bet. Not a perfect, tool, but that's the first thing, is finding a provider, a healthcare provider, or a physician that can really help you, that understands what's going on.
Yeah.
That's the first thing. And then, and then things like just educating yourself. Like, so when my course is released, or like just like menopause.org has tons of stuff too for patients.
Yeah.
Just like what's going on, what's brain fog, why am I having this? Like, what are the options here? And then I think of menopause treatment, like, and perimenopause treatment is really like a toolkit. So we say like, lifestyle stuff like what you're doing. So nutrition, strength training, super important.
Yes.
Exercise, you have to preserve your muscle mass, all these things, plus pharmaceuticals. You can use them where they are needed. And I think there's been a lot of fear around them due to many reasons. There isn't really a huge reason to be fearful of them. But I think that there is many options that you can do, but it's never like a one size fits all. This has got to be,
right.
You have to take hormones and you're not healthy, or if you do, you're better. It's a very nuanced conversation that has to occur with a healthcare provider, I would say.
Couple follow-up questions. Do you always or most of the time run blood work? Is that part of your process?
I do.
Okay.
Yeah, I do. I think that's one of the biggest challenges that I hear people say is my physician didn't check my blood work. And what irks me a little bit about that is it is what is traditionally taught, unfortunately, in OBGYN training. And here's the reason. And I think if people can understand this will help, is that because remember, the menopause definition is a clinical one. It's you didn't have a period for a year. The perimenopause definition is also mostly clinical as well. It's listening to you, believing what you're telling me, right? That's a big thing. Believe you. Believe that what you're telling me is true. Here, what's your menstrual cycle? What's your, interval there? What are the symptoms? When do they occur? Blood work is really just supporting. It also rules out other conditions, which is the way I view that. So in a perimenopausal patient, I do get blood work on every patient initially, and then I'll get it intermittently for certain reasons. But yeah, I do it because I find it validating to symptoms. I think the reason that it's not done is that, every day in the menstrual cycle, your hormones are at different levels. So if I just get a random follicle stimulating hormone and estrogen one day, that's going to be dramatically different on day 3 of your cycle than day 14, things like that. So we have to have the right interpretation of the lab results, which I think is not being done when you're not seeing like a menopause specialist, if you will, or expert. And so that is a huge thing. And as a cycling patient, you have to interpret the information correctly and then rule out other conditions that it's not. So it's not your thyroid. It's not anything else going on. This really is just perimenopause, which is your eggs starting to retire slowly. They're starting to run out. But it's a slow decline and everybody does that differently and everyone feels these hormone fluctuations differently, but it's quite chaotic in those years before the periods stop.
Yeah.
And it's probably the hardest time. I think it's actually easier once you're not bleeding anymore.
Interesting.
Yeah. So
I just heard Cameron Diaz is pregnant at like 51. Did you hear that?
I didn't know.
She is 51, Cameron Diaz, and she is pregnant. Yeah, look her up on Instagram.
I'm
sure. That's probably true.
Just saying, biologically speaking, more likely donor eggs.
That's probably true.
Or maybe they're hers from before. You never know.
That's
but they're not 51-year-old eggs.
That's a big aspect. Is people, are freezing eggs more and more. But I want to dive into some of these symptoms. So I am 38, just turned 38. I distinctly remember I am leading a training for our VIP community. It's got to be a little over 2 years ago. So 2.5, 3 years ago, and I'm pregnant. So I'm like very pregnant. And Alex D. Oliveira is in the training with me. And she goes, perimenopause starts at 35. And the amount of drop that happened in my jaw. I mean, my jaw was on the, and I'm like 36 and I'm like, are you sure? Because I'm pregnant. I don't even, I was like,
no,
really?
You can still get pregnant.
Well, I did.
Absolutely.
I was like, well, I
That's
had,
another challenge.
yeah, I'm like, oh my God. So I'm like, my jaw is on the floor. There I am pregnant, but I will say kind of, I'm 38. I'm now more in tune with my body than ever before. And I am experiencing some of these symptoms, but it's like, is this something I need to resolve? So I do 2 days before my period, I have worse insomnia than usual. I've had insomnia my whole life since high school, so it's worse than usual. I get 1 or 2 hot flashes right when I lay down. So it's like I lay down for bed, get super hot and like, ugh. I don't get the night sweats. Postpartum, I always got the night sweats and that is for, I would put a whole other like PJs next to me and I would just strip down in the middle of the night postpartum and change out my PJs because I'd be just sopping wet. And so, but it's like, do I need to do anything now? Is it like, is something wrong, or I'm just like tracking it and like, oh, noticing it? Or should I be like, oh, this is not good that I'm having.
I think in the case if it's like really mild, certainly I think it's fine to track and watch, because what you'll find is that like every month may not be the same. Very common to have like, I had a really good month. I felt great. And then the next month you're like, what the heck? Like,
and
I'm
I do
having
track it. You're right. Yeah, that is true.
So yeah, if it's bothersome or disruptive to sleep, which is like super important, that's part of like, this menopause toolkit I was speaking about, is like, you need to sleep. So if you are having disruptive sleep like frequently, that's like the first thing I like to fix for people, is like trying to help you to sleep properly. So if it's just like, hey, it's like every now and again, and oh, that was a bad night, and then you have 60 good nights. Well, okay, that's all right to watch. But I think like if it becomes a theme or it's disruptive to your life, you absolutely should treat it. And there is a lot of data now that shows that the worse and the more frequent and severe like hot flashes and night sweats are specifically, there's actually an increased risk of cardiovascular disease and mortality.
Whoa.
So yeah, so if you do treat it, you're going to bring down that risk to, just your baseline. And there's obviously other factors in heart disease risk, family history, personal lifestyle, all of that. But it does, like, I do emphasize, not with mild symptoms necessarily, like what you just described probably, but like someone that's like, I am just going to power through this. I heard that hormones cause cancer, which they don't, but just things like, I'm going to just suffer through this and, not do anything is always, I would not recommend that, because you really are increasing your risk for heart disease and mortality.
Interesting. Wow.
Yeah.
Wow. So once it becomes more disruptive and it's not just, once a month or twice a month.
Yeah, like a day or two, I think it's fine to watch.
Got it.
Yeah.
Now, my other follow-up question is for people with cancer, because I was just on a trip and one of my gals, she's like, oh, I've had breast cancer, so I cannot do X, Y, Z, A, B, C. So I don't really know what to do or where to go. What is your opinion?
Yeah, so it's hard because breast cancer is typically hormone receptor, positive in many cases, although there are hormone receptor negative cases. There's definitely a role that can still be played of hormone therapy if needed for disruptive symptoms, especially in hormone receptor negative patients. If more majority or more hormone receptor positive, but basically there's more and more studies being done now that show we're trying to really find how can we help breast cancer patients better. Certainly while you're undergoing a new diagnosis and treatment, hormone therapy is typically off the table for you, but there are other non-hormonals, and I take care of a lot of breast cancer patients that we, get their symptoms under control with non-hormonal treatment. So for their hot flash and night sweat. And then one thing I think that is often not given at all, which is a huge lifestyle issue, or not lifestyle issue, but issue with like sexual health is, and genitourinary health, is vaginal estrogen is actually safe for breast cancer patients. And a lot of people don't know that, and just they refuse all types of estrogens. So that is like super important. It's like skincare for your vagina. You should really be offered that. That shouldn't even require like discussion with your oncologist, but it still does in many cases. Many practitioners are not comfortable with even vaginal estrogen. So
got it.
There's so many options, but there are options for breast cancer patients. And as we get more and more data, we should have more protocols, I hope, or some sort of, guideline to follow on, who really has a risk of recurrence with using this medication versus not. Because in my mind, it's like, well, her quality of life matters.
Yes.
Her sleep, her heart health, her brain health, her bone health matters. So what's the risk of all of that and not treating her symptoms properly versus her risk of breast cancer recurrence? So it's like very important to really understand. And I think that the thing for so long has been, well, nobody really knows. They just say it's all off the table. You can't use anything. And that's not really true. You can use, there are options. Yeah.
I think the black and white thinking,
you can't have
it
black
has
and
to
white.
go. It has to go. Yeah.
It's very nuanced.
There's one.
And that one does require an expert, because it's going to be hard to get well, even for an average person to get hormone therapy or attention to their menopause.
Right.
Think what a breast cancer patient goes through.
Yes.
It's even worse
Yes.
for access.
Just even access to a little bit of testosterone or a little bit of this or that. Yeah, for the energy. And like you said, it's a quality of life issue too, but you have to find the right advocate or someone like yourself who is looking at the current data and not just so rigid on, well, no, you can do it. Like, I think that's a really important component is just finding that
the right
advocate.
Healthcare provider is the key, but it's harder than you would think it should be for sure. I do think it's going to change, and it is changing, but it's going to take time.
Yeah.
And so for now, you have just a lot of difficulty.
Share with me in our final couple of minutes here, what's your perspective on the increase? Oh man, we could be here for hours because I have like 27 other questions, but what is your perspective on the increase in ovarian cancer, breast cancer in younger and younger people? Do you have a perspective on that? Do you have a tip for us of prevention?
For breast and ovarian cancer? Well, I think a lot of the breast cancer specifically, they're pretty different cancers, but breast cancer specifically is the most common. And that in general, most of the factors that actually increase your risk are probably environmental and, lifestyle. So, and this is a really something I hear a lot from most of my perimenopause patients too, is they think, well, if it doesn't hormone therapy cause breast cancer? And actually, I try to reframe the conversation because really having alcohol, on a regular basis or being obese or, smoking, those actually increase your risk of breast cancer much, much more than body identical estrogen and progesterone, that's being used for menopausal symptoms. And so most of it, I think, is probably environmental. And, some genetics, sure. But I'd say the vast majority of breast cancer new diagnoses are actually people that don't have a family history. And so, it's probably that more than anything that we're giving,
Right. Okay. I lied. I have one more question. So I get a lot of inquiries regarding working out around your period, whether it's someone who is trying to get pregnant or in perimenopause. There's a narrative going around the internet that you should kind of take it easy with fasting and workouts a few days leading up to your period. I just to kind of jump in with my opinion, I haven't found that to be a necessity personally. Now, bioindividuality is extremely important, but I personally am able to work out specifically like strength training at like a fairly consistent clip throughout the month. Now, again, I'm 38, so maybe this will change. And I have, 50-year-old trainers on my staff who I ask all the time, what are your thoughts? I've never kind of vacillated my workout intensity throughout the month around a cycle. But what are you seeing with that?
I think I hear that a lot too. I have that question a lot. And I think that the key is to keep moving. If you have to modify some in, the week before your period, or let's say you were up all night with night sweats and you feel terrible the next day, I think you still go. You still do. You may need to modify what you do, but certainly I think better is to get help with those symptoms and to get, again, treatment for perimenopause. But you do have like a natural increase in your energy with your cycle when your period starts, if you are cycling, due to the estrogen increase that's occurring. And then you are always going to have a natural decrease in energy and feel just a little bit more fatigued before your period starts. And that is going to be probably more significant for people who are perimenopausal and really struggling. Let's say you're a person who's having 2 weeks of really terrible symptoms before your cycle. Surely that person needs to seek care to feel better in order to be able to keep going with their life. So if someone feels that, their symptoms or their period is stopping them from their workouts, I would say that's a sign you should be getting medical help for that issue, because it should be really a pretty mild bump in the radar. It should be like, I can keep doing this. I'm fine.
That is good insight.
We've all felt tired about to work out. We're like, oh, I don't want to do this. But you do it. And I think it's something to look out for.
There's a law of diminishing return per the research with too much HIIT throughout the week. There's a law of diminishing return per the research with too much long form cardio if you're maintaining a calorie deficit. But there is research that says even if you do have a little sleep deprivation, still doing that strength training workout will actually still be of benefit to your body. And so I'm just hesitant when people come at me and ask me these questions. Should I take it easy? Should I not work out? Should I not fat? I'm like, I don't need to give you an additional reason to kind of pull back.
Yeah. No, I think
listen
you
to your
keep going
body.
for the most part. But listen to your body. If it's something really severe, of course, if you're going through a big medical issue, it's a little different. Yeah. But certainly just like natural fluctuations within a cycle are going to happen. And I think if it's really affecting you and you're asking yourself if you should be cutting back a lot, then you should be getting help.
That's the key. And I'll have someone on at some point that has a different perspective. Well, they'll say, oh, no, this is, we need to really scale back, blah, blah. And I think that maybe, it'd be interesting to hear that perspective, but I agree with your perspective. And I think the key was, if this is very disruptive to your life, then to where your energy, then if something feels off, something's off. If something feels wrong, get help. And maybe it's the people who are struggling through perimenopause and they're going to their doctor and their doctor's saying, oh, there's nothing we can do. It's hormonal, blah, blah. Those are the people that maybe, you are having the bigger swings. So you need to pull back, scale back. But let's all chase optimization and energy and strength and feeling. I look at Lee Bergen on my team. I'll introduce you to her, 51, top of her game. A specimen. I mean, phenomenal muscle mass. Just, sailed through her 40s. Now 51, just thrived. That's my goal. Like that's who I want to be. When I grow up.
Muscle gain and preservation will equals longevity. Like you have to.
So, Alex, where do we find you online?
So I have my Instagram page, which is Dr. Alexandria Reyes. And then my practice in Tampa is Magnolia Gynecology. So that's our physical practice. But there'll be a lot of really new, exciting opportunity to work with me on via telemedicine. Right now, if you call the office, there's kind of a wait. So we're expanding, we're growing. I'm trying to listen to what my patients needed and try to eliminate some of the wait time a little bit so they can see me sooner. So that'll be on my Instagram page. And then, I think that's the best place is there. So
awesome. Yeah. Well, thank you so much. This has been so fun and informative. We left with quite a few takeaways and we just really appreciate your time.
Thank you for having me.
Bye, everyone.
Bye.